Hello, everyone. I'm Brennen Hodge, founder and CEO of Citizen Health, and this is our third episode of Rebuilding Healthcare, and the topic is price transparency. Now, we've all had issues with trying to figure out how much something is going to cost beforehand in healthcare. And the truth of the matter is, it doesn't need to be that way. You go to the car lot, and you can see breakdown of the price on every vehicle out there. You know what it's going to be. In healthcare, it's not that way. So we have a really good panel of guests today that is going to talk about some of the problems that's withholding us from having these transparent prices and how we can move forward and actually help bring this to be. So with that, I'll just lead straight into Dr. Ernest Sussman. He's going to give a recap on the Free to Care conference that happened in DC this past week. Dr. Ernest?
Okay, thanks. There's my usual delay here.
No problem.
You guys see that?
Not yet.
Oh. I think it's asking me to give privacy to Zoom. I'm sorry. You don't see my screen?
Not yet. There we go. Yeah, there we go.
All right. All right. So this meeting last Monday, Free to Care in Washington, David was there, and one of the sections was transparency. So being that's the topic of today's talk, I decided to just give a couple of bullet points. There were two speakers. One was Dr. Randy Brinson, who's a GI in Alabama, political activist. And then Dr. William Grant, who's an orthopedic surgeon in Charlottesville. Dr. Grant had pretty much, he overlapped a little bit with Dr. Brinson's talk. So both talks were excellent, but I'm just going to pull some of the bullet points from both of them together. I'm sorry I don't have Dr. Grant's picture, but in any event, he was talking, one of the topics obviously are these non-for-profit hospitals, which obviously aren't about non-for-profit, but some of the problems that he highlighted were that they're hiring J1 visa doctors and getting paid sometimes almost 2.5 times reimbursement what Dr. Brinson or me as a private practice urologist would get for the same service, doing it in the same community, which creates a very unfair competitive advantage and actually could put doctors out of business. The other problem, of course, is why we're meeting today, is we don't know what we're paying for. The charges are just come up out of nowhere. You really have no idea what a syringe costs or a Band-Aid or what have you. There's network issues. He told a story about an employee in a hospital that had no other hospital within like 70, 80 miles, and this woman gave birth and had to have a cesarean section. Before they would do the cesarean section, they made her husband go get a cashier's check for $500 before they would proceed with the procedure. Something happened with her insurance, and the bill was like $35,000. So after all the haggling and all the headaches that we all go through after getting the EOBs and dealing with insurances, Blue Cross covered $25,000 of it, and then she was responsible for the remaining $12,000, and they actually garnered her wages as she was an employee there. I mean, it's really ugly. So these not-profit hospitals are not very nice players. And then both doctors talked about, which we all know, the certificate of need, which is still active in many states and also DC. which essentially blocks out competition. Dr. Brinson, they tells a story about a surgery center. I don't know if it was his or somebody else, where they actually had to uproot the surgery center and move it a couple miles away. So it blocks out competition. I'm not an expert on CON, but when you look it up, it was actually started to try and lower prices and create more availability, especially for the poor, and it's done the exact opposite. It's stifled competition. And then the indigent contracts, where they're going to charge more for the other people, and I'll let you decide what other means, but those issues come up because they have to balance it and still make money. And some of these hospitals get tax-exempt bonds, which Dr. Dixon talked about during our first one or two online town halls. And then ultimately, in a roundabout way, this gets passed on to the taxpayer. So it's really a win-win for these so-called not-for-profit hospitals. And then he talked about some potential solutions. Obviously, stop price fixing and kickbacks, transparency, which is why we're here today, and certificate of need. As I mentioned, it's really used to weaponize against the doctors out in the community who really have skin in the game and putting it on the line, and try and end these hospital-employed physician agreements, which is truly anti-competitive.
I agree. All right, thank you, Ernie. Yeah, that conference was amazing. I couldn't attend, but I was watching it online, and I wish I was there now. There's some good stuff and a lot of good people there. And David, like you mentioned earlier, I would have liked to attended so I can meet people that I meet online. So next year, or maybe we can have 2 a year for that. But if you want to, could you? David was there, everyone. So he actually co-hosted that, possibly, or yeah,
we co-sponsored it.
Co-sponsored it, and if you'd like to shed a little light, some takeaways, and some high points there as well, that'd be great.
Sure. The Free to Care conference was born out of the desire for physicians to wanting to take care of their patients again without having all of the middlemen in between that relationship. Doctors want to fulfill their calling and be free to care, and that's what patients want too. And what has been very difficult in times past is for physicians to come together as one group to magnify their voice on behalf of the patient. This was our attempt to do so, and what I saw in DC this last week was absolutely remarkable. It's like nothing I've seen in over my 20 years of doing what I'm doing. So it was Dr. Brinson, Dr. Grant, they were invaluable. They had great messages, but we had so many other wonderful speakers that spoke in their areas of expertise, and that's been the wonderful thing. Of the 20,000 plus doctors we have as part of this group, we have people that are experts in various areas, and they're able to bring their expertise when it's needed at that time. So we're blessed to be in the position that we're in. Now, what you saw was fantastic, but what you didn't see was even better. That conference that we also got Dr. Ben Carson to attend to speak to us for a short time. It really spurred a lot of meetings that happened behind the scenes. I think I worked till nearly midnight that night, and we were in rooms with congressmen that wanted to talk about bringing in doctors and industry experts from that meeting to talk about how do we put together legislation based on what it is that you guys are talking about. We've never seen so many doors open like that before. Now, can we get it done? That's going to be up to the rest of the grassroots community calling their legislators and saying, you need to do this. We need to talk about transparency. We need to talk about getting the GPOs and the PBMs to not take advantage of the people that are actually participating in the care with the patient. So I'm very encouraged, and we absolutely will be having one next year. Whether we have 2 or not, we're not there yet, but we're getting closer and closer to really creating a wonderful footprint.
All right, I appreciate that. And I figured more was happening behind the scenes. That's where all the good stuff happens, all the good conversations. Now, I would definitely like to be a part in any way we can help with Citizen Health move that agenda forward, because I think not only physicians, you have to have physicians in there, but patients are also responsible for a lot. And bringing these two parties together, I think, is going to make the real change that we really need. And it's progress, stepping stones. So
well, we do have the ability to, there was a great deal of interest, and thank you for bringing that up. At the meeting, there were a number of organizations that were not physician groups, not physician grassroots advocacy groups, and they said, we want to be a part. And so we've created a new category that are non-physician affiliates. And so there's absolutely an opportunity to participate and be a part of the effort. All
right, good deal. Spread the word. All right, well, everyone, let's just hop right into some conversations here about price transparency. And I think we should start by getting some accurate descriptions, some definitions on price versus cost. You see that used interchangeably, and people get it wrong. And I want to ask Dr. Kevin Wacasey if you would like to explain a little bit about price versus cost and some of the common misconceptions around those.
Well, actually, I wrote an entire book about buying health insurance and healthcare. And in my book, and part of my online mantra is one of my taglines is, it's not the costs of healthcare that are outrageous, it's the charges or prices, as you say. And, I go through in this first book that I wrote all the story about how that is used. It's sort of like they took a page out, and when I say they, I mean the healthcare and health insurance industries, politics, pundits, the media, policy experts even support this idea that the high cost of healthcare. I make fun of this phrase, the rising costs of healthcare. Everything is rising cost of healthcare. And it makes you think that healthcare is inherently costly or expensive. And I point out that, it's not. I mean, for a syringe, it's a few pennies. For a needle, it's a few pennies. The most expensive antibiotic that I administer to patients in my practice, not the most expensive antibiotic out there, but the one that cost me the most to purchase it is about $3 for an injection for a dose of what's called clindamycin. So the costs of healthcare are deceptive. And in my book, I say that they took a page out of the anarchist's handbook and they created a crisis where one doesn't really exist. And that is by saying the rising cost of healthcare, they have a whole population now in fear of these $35,000, cesarean section charges, which how much should a C-section be worth? I don't know. It should be worth whatever the market will bear. And that leads to price transparency discussions. But is it $35,000 worth for a C-section? I just had a cataract fixed in my left eye last month, and I shopped around. I have health coverage. I don't have health insurance, but I have health coverage. But guess what? It doesn't cover pre-existing conditions, and my cataract was a pre-existing condition when I signed up for this. But think about this, because I shopped around, because I looked for price transparency, and because I was a real stand-up consumer for myself, I got this done. I got a vision-fixing procedure that's permanent. I mean, my sight is back. It's 100%. It's wonderful. I got it for around $5,000. Now, that's less than the price of a crappy used car. But yet I was able to fix my sight for $5,000. It's a lot of money, don't get me wrong. Would have been a lot more money had I not been a good consumer and looked for that price transparency and been upfront and steadfast in my saying, look, I know that you could charge me $15,000 for this same procedure, but let's get to something real here that you and I can agree on. So price transparency is important. It's a necessary part of any economic transaction, and it's sorely missing from healthcare these days.
Definitely agree. So how can transparent prices actually make an impact in healthcare? Because we all know that just putting a price out there, like you said, is $35,000? Is it $5,000? How is that really going to make an impact? Are consumers really going to shop around like that? I know we're smart enough. When I say consumers, I'm a consumer. We're all consumers just like you. Like, is that really going to make an impact? And how can we push that forward to really make an impact?
I'll tell you a funny story. I'm an emergency physician by training, and I used to work in what are called freestanding emergency rooms here in Texas. And this is what led me to my whole kind of seeing the light, my epiphany, and getting into the direct patient care movement, where I don't accept health insurance. And part of the reason was I could see these patients getting ripped off at the counter. I would hear them come in, and the receptionist would say, well, you have a $3,000 deductible that you haven't met this year, but your copay today is only $50. And the patients were like, wow, $50, that's great. They didn't even hear the other part. Then I got to see them a few weeks later when they would come back screaming for my head. I can't tell you how many times I had 911 punched up on my phone in the back in case shots were fired, because they were screaming mad that they had been billed $2,700 for their sore throat visit for 5 minutes of my time 6 weeks prior. So I think that people need to start getting into this with the cure to all this, believe it or not, I don't mean to jump around too much in this, but as I point out in my book, the very closing of my book is that my first book is that consumers are incentivized. The health insurance industry has fixed this for everyone. And what I mean by that is by increasing their deductibles, by getting too greedy, by increasing the patient's out-of-pocket responsibility now, where patients have, on average, $2,000 across the U.S. in deductibles, sometimes 10, sometimes 5-figure deductibles for families out there. I can think of no better incentive, guys, for people as patients to become consumers than that. The problem is that the health insurance and healthcare industry still convince people that it's not about a deductible. It's not about an out-of-pocket maximum. It's about your copay. It's about, and people look at these balanced bills and they say, why am I getting billed from the doctor, the nurse, the pharmacist, the facility, the guy who cleans the carpets on Saturdays? Why are we getting a bill from these people? Because you haven't met your out-of-pocket responsibility. And price transparency is a necessary part of creating consumerism, but as long as people can hide behind, or not people, as long as the health insurance and most of the healthcare industry can hide behind copays and these lies that have been told to Americans for decades about health insurance coverage, as long as they can hide behind that, price transparency is going to lag.
Yes. Now, on that note, that CMS ruling for price transparency in hospitals, you have any light to shed on that? Because I think that was a good step in the right direction, but still, they're posting their prices in JSON format or CSV, and I actually started looking at everything. And also, I'm going to put a plug in here real quick. We're crowdsourcing a project, and I'll have a link at the end of this on the video. We're actually have a list, a spreadsheet of all 6,000 hospitals now, and we're putting a URL for each one of their chargemaster URLs, their links, and we're actually going to extract all that data. We're going to clean it, organize it. It's going to take a while. We're going to have a heat map of prices across the country. Now, it's going to be difficult, so we're going to crowdsource this. So at the end, or I'll actually share the link here shortly, and we can each person can find 3 hospitals, put the URL, and we'll do the hard work to make it happen.
All right, thanks. Yeah, that's great. That's great. I did a video on price transparency on my YouTube channel. It's called "Why Can't I Find the Prices of Healthcare?" And in the video, I poke fun at the fact that, if any doctor or healthcare provider, hospital, whatever, is going to post their prices transparently, what they have to post is the chargemaster. And a big reason we don't have price transparency, and guys, if I'm dominating this, please interrupt. I can talk all day, and I will if you let me. But the bottom line of why there's no price transparency right now in healthcare is because of managed care. It's because of managed care contracts. The fact is that even for something as simple as a doctor's office visit, if I am a physician who accepts health insurance from 6 different carriers, I've got 7 different prices for the same exact office visit. I've got my prices with these 6 different health insurance carriers. Then I have my chargemaster. Then maybe I have an 8th price. Maybe I have a cash price. But I can't post the cash price. I can't post the real price for it, at least not in the light of day, because then the 6 carriers would see that, and they would negotiate the next contract based upon my lower, you would suspect lower cash price. So the way healthcare is priced.
Not only Kevin, and I want to just make a point, and you gave me permission to interrupt. So,
sure, yeah, please.
It's not only that. It's not that they will use that as leverage to negotiate. It's actually illegal.
Okay, yeah.
Both federally and in the state of Texas. In Texas, you can only have one chargemaster. You can only have one cash price or one charge list.
I did not know that.
Yeah.
Wow. So you're saying it's not even a civil tort contractual violation. It's actually illegal.
Correct.
Is it a civil penalty or criminal penalty? Can you go to jail for doing this?
Oh, I don't know if it's criminal. I don't think it's criminal, but
okay.
But you can't have charge. You cannot charge anything less than Medicare or Medicaid if you are a Medicare or Medicaid provider.
Oh, I knew that. Yeah.
And then in Texas, you can't have one charge list that you charge insurance companies and one charge list that you charge cash.
Oh, wow.
Now there are ways that people get around it. They call it prompt pay discount or things like that. And that's what I've called it. You use the time value of money.
Right.
Economic tool to help patients out. But no, it's a legal issue as well.
Wow. So there you go. There you have it. This is why we can't have price transparency. This is why we can't just turn on the light and boom, we have price transparency. And I point out in this video that I made, it's that politicians talk this because it makes a great game around election season. Oh, price transparency, price transparency. But the bottom line is the only way to really get around this, in my opinion, and David, please feel free to chime in on this one, is to repeal the HMO Act of 1973, which is a law that desperately needs to go. As bad as Obamacare needs to go, the HMO Act of 1973, get it out of here. I have this phrase I coined on Twitter. It's set to the Journey famous song, "Don't Stop Repealing All These Laws, Congress." And the bottom line is that that HMO Act needs to go. I think that would go a long way towards crippling health insurers' abilities to negotiate these managed care contracts and set up networks. You'd see price transparency pretty quickly, at least in my world, if that were to happen.
And I think, if I may, Brennan, I think it's important to say this again. I said this in the last town hall, is I'm not anti-insurance. I don't think anybody on this panel is anti-insurance. Insurance has its proper place, but we use it wrong.
That's right.
Currently, we have prepaid healthcare or prepaid medical care, and that's not the same as insurance. And if you look at employer-based insurance, 60% and up are really the employer. It's self-funded, so the employer is the insurance company, and the big name, brand name organizations are third-party administrators. They're TPAs.
Can I interject something here? And what's really interesting is when employers do that, when employers use these BUCAs and things like that as administrators, that allows three things to happen. Number one, you're allowing the third-party administrator, the insurance company, to tell you where your employees can go to get their health care. Number two, you're letting the health insurance company tell your employees when they can get their health care approved. And number three, and most importantly, for these self-insured companies that are paying for a lot of this health care, they're letting these third-party health insurance companies set the price for that health care. It's a disaster all around.
So in Vegas, there's a dominant player. They used to be called Sierra, and now they were taken over by United. And they're the dominant player in town, especially with all the casinos here. Yeah. And it's amazing that you have very well-to-do people with very good jobs mixed in with this crappy insurance. Right. And doctors and some of the panels that they put on there, and in my specialty, are absolutely horrible. And these are people making, big money, stuck onto the worst doctors in the city.
What's funny is they think they can't, I have to go see this doctor because, yeah, it's a joke. It's so.
I talk about when I first online, I talked about the networks and why do we have networks, and why can't you go to anybody? Like at this health to free to care conference, Dr. Brinson talked about, I think it was he or somebody else, that if insurance was applied to like auto insurance in the same fashion, you'd have to get approval to go get your car filled with gas.
Well, I like to say, go ahead.
And it'd probably be like, $100 or it's a couple $100 to fill your gas tank.
That's right.
So you made that analogy.
I like to say that it's funny that people, and I do a series of short videos on my YouTube channel that are a minute long each, are called Healthcareonomics 101. And in my very first one, I talked about health insurance versus pizza and how it's funny that you wouldn't let a health insurance company choose what goes on your pizza tonight. So why do you let them choose which doctor you get to see? I mean, the psychology behind that, if you really think about it, it is amazing that people feel like they are roped in, that they are brought in and corralled, and they have to obey these rules by the health insurer. And forgive me for going on, but what that all springs from, okay, what that all results from, the ultimate source of all that fear, that anxiety, that ignorance even, is the fact that they believe that healthcare is so expensive, so costly, that they cannot possibly afford it without health insurance. Sad.
The example that you gave about standalone ERs, we do have a problem with surprise billing here in the state of Texas and across the country. And there are a lot of politicians and now the insurance companies say, we want to fix the problem of surprise billing. Well, they created it.
That's right.
We wouldn't have the issue if there were networks. Networks are basically an artificial market.
That's right. They create a crisis where none exists, and then they put themselves out there as the solution. That's right.
Well, they come in as a savior. So, we talk about free market. Free market is really difficult in healthcare. Is it possible? Absolutely. We see these direct primary care providers. They are leading the way. They are the tip of the spear when it comes to the free market in this country. But in large part, our healthcare industry does not represent or look like any kind of market-based economy. And it hasn't even before the ACA. We need to continue moving in that direction. And I think we have a good start, but it's a start. You talked about the pricing requirement by CMS, Brennan. I agree. It was a great start. I like any movement towards transparency. Did it really solve anything? No, but hopefully it will move in that direction. And we need to applaud any effort that is shining light on the issues that have been living in the dark.
Yes, and hopefully this spreadsheet can take off a little bit. If it does, great. If it doesn't, that's fine, because it's a big project. But just imagine having a heat map of, say, one MRI price with contrast if you need, and just kind of have it just a heat map across the country, what every single hospital will charge for that, and just go down the list, just so you can be aware of it. And I think then hospitals could start to see, oh, I'm this much different than everybody else. And then they can just start working in the background to come to a rational price. And I think that's really where we need to get to, is bring some rationality back in pricing.
Well, but again, if I may, you're not anticipating this, but that is assuming that we're talking about a free market here.
True.
Now, if I have a gas station across the corner from all of y'all, if we have 4 gas stations on the same corner, you better believe I'm going to look at what your prices have done overnight, and I'm going to adjust my price accordingly. So we can do that in a free market scenario, in a free market situation. And that would work great. And this would be a great first step. And it is a good first step. I'm not knocking it. I was only laughing at the idea that they're having to post their charge masters. But the bottom line is that what stands in the way, again, of true price transparency, of true competitive forces coming in and letting hospitals look at that heat map and say, they're charging this. What stands in that way is all those managed care contracts. All those contracts that they have to negotiate every year, every couple of years, where they're trying to charge this, the health insurance company is trying to pay them this, and they meet somewhere in the middle. And the reality is we haven't had a free market in healthcare. David's exactly right. The last time we had a free market in healthcare, A, doctors couldn't do anything for you except bleed you to death, and B, they were usually paid in chickens or whiskey. But since then, since the advent of health insurance and third-party payers, we have not had a free market in healthcare. But here's the deal, and I'll shut up after this. We should have a free market in healthcare for most of healthcare, because as I point out in my first book, the vast majority of healthcare, and I think Dr. Sussman will agree with me, is routine, regular healthcare that you just need on an ongoing basis. Rarely, relatively rarely in your life do you need to see a specialist. Do you need some specialized care? Of course, that changes as we get older. But for most people, the vast majority of folks, healthcare is a routine, regular, predictable event and occurrence, and it should be priced and shopped for, and it should be consumer-oriented as such.
Yeah, Matthew Rail, he's listening in here, chatting, and he said, where was this at? Basically, it's the out-of-pocket cost, but fundamentally, people don't understand that insurance is a financial tool for risk and not just a payment for healthcare services. I think that's where we're having problems with consumers, is they think they have that insurance card and that's just a credit card. This is just payment for everything. I'm gonna disagree with David. What David said a little bit ago, and forgive me, David. I love you, man, but Texan to Texan, I got to disagree with you here. I'll arm wrestle you over this to decide who's right. But as I wrote in my first book, what we have now is not prepaid healthcare. What we had before, when I was born, I put the receipt for my birth in 1968 for my birth in my first book, and it paid, the health insurance back then paid 97% of the charges. My dad had to write a check for $10.75. That was prepaid health care. And we got Americans, or the health insurance industry got Americans stuck on that. They got addicted to that. They got Americans addicted to that idea. But now what we have, as I argue in my book, is that what we have now is a true health insurance model. In other words, it's something that isn't prepaid health care. Because now you have these high deductibles that mean that you have to use this much like you use your car insurance, much like you use your homeowner's insurance. And that is, relatively rarely do you get to call upon the benefit unless you have a catastrophe involved. The problem is Americans still believe, they still think that health insurance is a prepaid healthcare model. But the health insurance industry has moved beyond that. They have moved into the true insurance risk mitigation model. It's just that Americans don't get it. They're still buying these copay ideas and these low deductible ideas.
Well, conceptually, it's prepaid healthcare. So I think we're on the same page.
Yeah.
Which is unfortunate because I was going to accept your request for a trial by battle. No, but that's right, and Dr. Rail is correct. It's the issue is what comes out of pocket. There is a false sense of security by having an insurance card in your wallet. That pretty little card in your wallet doesn't really do much, but it gives people peace of mind. And that's what a lot of Americans want, is they want peace of mind. They want to know that they're going to be taken care of and their family members are taken care of when they're at their most vulnerable.
Yeah.
So it's important that that they understand that insurance really doesn't do that anymore. The traditional definition of insurance is the transfer of risk. And that's what the Texas Department of Insurance teaches its brokers. There's no transfer of risk in health insurance. So much of it is still on the side of the patient, and it's unaffordable, and it's just not.
Health insurance companies now, if you start looking at it, they're looking like investment banks. They literally buy up, working on the buy and sell side. I mean, they buy up doctors' time, turn around and resell it in form of insurance to patients.
Right.
And all they're doing is just moving services around, moving time around.
That's right.
Looking at that light, they're just a financial institution that's there just to make more money. It's really not for the benefit of the patients and the physicians anymore.
Well, and I want to jump in there because I think it's important that we believe in patient care, absolutely, without question. But we also need to be careful that we don't sound like we're anti-capitalist. We believe in the profit. It's okay to make a profit.
Absolutely.
That promotes innovation. It promotes creativity. But you don't do it at the expense of the patient. I think that's.
Well, how much is my time worth? In an ideal world, it's worth whatever the market will bear. In an ideal world, yeah, absolutely.
That's where we're getting at. Is we need rational profits too. I mean, rational prices and rational profits, and that's having this black box of insurance that just creates irrationality all around, even on the profit side. And you can see that to continue to eke out profits is not putting the patient's best interest in mind. So we got to find that common ground where this, as a financial instrument, it actually works for everyone. Where's that at? I don't know.
One of the things that we talked about at the conference was the repeal of the safe harbor to mitigate the impact of the group purchasing organizations, GPOs, and the pharmacy benefit managers, the PBMs, because the price of medications and supplies, both on the inpatient and outpatient markets, are just extraordinarily high, and they've doubled and tripled and quadrupled in some cases over the last 20 years. It's going to be extraordinarily difficult, from what we found, to get that safe harbor repealed because of political maneuvering. But one thing that can be done, that everybody can get on board with, is transparency. And that's what we need to push very, very diligently, not just with pricing in the hospital and with the doctors, but also with the middlemen. What does CVS Caremark get and the insurance company get when we're having to pay $600 for a vial of Humalog? I had this graphic. Eli, for a list price of $594 that a patient pays at the pharmacy, Eli Lilly gets $135, but the PBM and the insurance company gets $407. Most people don't know that. We may not be able to change anything legislatively right now to impact that, but I think we could get there faster if everybody knew these numbers.
Yeah, that's key. That's key, is getting the word out. Unfortunately, when it comes to patients, when it comes to ordinary Americans, especially employees on their employer health plans, it is amazing the mental inertia that one has to overcome to get people to think outside the box, because as long as they're spending someone else's money, they really don't care. And in one of my podcasts that I did with an employee benefits specialist a couple of weeks ago, Curtis Cannon, he mentioned he worked for Blue Cross Blue Shield for 13 years. And he was amazed at how, even with these big groups, these 10,000, 100,000 employee policy, the premiums are going up double digits every year. And what employees don't understand is that's eating into their salaries. That's eating into their raises. They're not getting raises because their health insurance. And what's even more amazing is the employees still insist on those so-called great health insurance benefits. They want everything covered, no matter what the cost, and it's a vicious cycle that's eating itself. It's got to stop at some point.
Yeah.
So what do we do to move forward? How do we make this a reality? I know direct primary care is moving forward and really paving the way, being those pioneers. You see imaging facilities like Green Imaging, surgery centers now like Oklahoma. Is it just a continuation? You just got to spread the word. I mean, I know I got the list of a couple acts that need to be dropped and some laws that need to be changed. I think that's what it is. I think it's education. I think we just need to get it out there and let people understand that there's a better deal, there's a better way, and just push it forward.
Education and advocacy, Brennan.
Yeah.
People need to have their voice be heard, whether it be through their organization or a coalition like Free to Care or them individually. Get to know who your representatives are at the state and federal level. And better yet, have them get to know who you are.
Yeah, absolutely.
So that you can become an advisor to them. Once you've demonstrated your ability to understand the law and understand your industry, they're going to rely on you. I'll give you this. A lot of the experts in DC, their base of knowledge is pretty superficial. Those who work in the industry have a lot more experience and knowledge. But as far as things that I would love to see personally, I've got a list here, so forgive me for reading. Of course, having not only the charges, but getting to the point where people understand the allowables. That's important. Even if it's just the patient, having them exposed to what the allowables are before the service and not just on the explanation of benefits after the fact. The transparency of all payments and retained revenue by everyone in the pharmaceutical supply chain. We talked about that as well. Establishing site neutrality. Whether you go to an urgent care, a doctor's office, an emergency room, what you pay and how much you pay is just dramatically different for the same service. So, and for Medicare and Medicaid, it's still vastly different. It could be 2 to 3 times if you're in a hospital versus a standalone facility. And again, the same service. I recognize that the square footage in a hospital is very expensive, but we need to get to the point where payments are site neutral. I think that's going to contribute quite a bit. Something we have here in Texas, the employers have a great deal of difficulty looking at claims data for their own employees.
Yeah.
That's something that we need to get them to be able to see with relative ease.
Thanks, HIPAA.
And then, patients that get sent to court and to collections, having never seen an itemized bill that makes sense with a full description, that shouldn't be the case either. I think people need to understand what it is they're being held accountable for. But when you go to these facilities, they make it extraordinarily difficult to see what it is that you supposedly purchased. I can tell you that if I sit down with anybody, and I've done this, that we can eliminate with ease 25% of that charge.
I would say that the most important group that we need to hit are patients, people, ordinary Americans who are having to pay more and more for their health care with their rising deductibles and out-of-pocket responsibilities. I remember when this is 3 years ago, I went to have a colonoscopy of all things. I'll admit it. I'm a big fan. And I walked into the surgery center to pick up the stuff to drink the night before, and they said, well, you want to pay your facility fee now? I had a PPO health insurance plan at the time that had a $2,500 deductible. They said, yeah. I said, yeah, what is it? And they said, $658. I said, now, wait a second. How did you arrive at that? And they said, well, that's the allowable amount. You mentioned allowables, David. That's the allowable amount that your health insurance will pay us. And so, we want you to pay it since you haven't met your deductible. And it started me thinking, I can't think of another industry where a consumer would walk into a place of business and agree to pay a price that they had no input into, that had been negotiated between two disinterested parties, both of whom are trying to extract as much money as possible out of the consumer. And I really think that patients need to understand that this underlies this seemingly innocuous, it's $658. Oh, that's not so bad. Thank God I have health insurance. Oh my gosh. Imagine what it would have been without my health insurance. Well, it may have been $300. I mean, it may have been $500. Who knows? But it would have been up to me to negotiate that with that facility. But since my health insurance is involved, guess what? I now found out today it's probably illegal for that insurance company or for that facility to negotiate with me directly. It not only violates the contract that they have with my insurer, it's probably illegal for them to directly negotiate with me. That's ridiculous. I mean, that's absolutely ridiculous. If I'm having to pay the price, I should have a say in the negotiation. Educating patients, educating would-be folks about this. To me, you want to talk about the biggest demographic, you want to talk about the biggest impact, that's where we need to go with this. We need to educate patients.
I'd like to make just a couple points. One is to follow up what's been said so far is that we need to, like you said, educate our patients. And we have the patients in front of us, whether you're in the urgent care or they're in my office or either in a primary care office. And we talked to Brennen about this, and he put out a doc, one of those Google Share docs that he was soliciting comments on. But I don't think there's any reason we can't get together a 1-page or 2-page, the shorter and the more simple, the better, that we can hand out like a tear sheet almost. It can be done paper or electronically to hand to our patients while we're in the exam room with them and let them know exactly what we're talking about. We talked about Congress. All the things that are said here are great.
Yes.
But until you get the patients involved, because they're the ones with the skin in the game and they're the ones who are getting hosed, nothing will happen. And they're the ones that vote for these idiots. And no malice there against our elected officials, but they're the ones that vote. So if we're looking at them and they trust us, most patients trust their doctor, right?
That's right.
And we have them right in front of us. They're our captive audience. That's the best possible scenario. We're handing them a sheet, highlighting these bullet points, and give them 2 or 3 things that they can say or do, whether it's at the ballot box or give them the email or fax or phone number for their elected official and say, go do this and you will lower your health care costs. And next time, maybe in a year from now or 2 years from now, you won't bitch at my front office staff about your $50 copay for your lousy Medicare Advantage plan, right? Right? So that's number one. Number two is there has to be a happy medium between your deductible and out of pocket and when you meet your deductible, whether it's $2,000, $4,000, or $10,000, right? So to get to Brennan's point about what, he listed 4 questions there on the email that he sent everybody yesterday. Just to answer some of those questions is, I think the best path is when patients have to reach in their pocket, just like they're going to get the gas or the pizza that you referred to earlier, that's how transparency will come about. Meaning get rid of those contracted negotiated rates. And that's going to be a hard sell, especially when you have a 40 or 50-man group who are very happy with their arrangement in whatever urban area that they live in. But when you get rid of these negotiated rates and contracted rates and allowables, and the patients know that they're paying for every dollar for dollar up into their deductible, believe me, transparency will figure itself out. Okay. And so I think that, again, there's a lot of in between here and there's little, nuances, but if you're paying dollar for dollar up until your deductible and you're the one setting your rate, you're setting your allowable by or through something like Brennan's talking about, the Metaplex, with a price transparency, and you can shop around for your best MRI or your best ophthalmologist is going to be a good doctor and give you a fair price. So that's number two. And then you're paying along, and then, I'm not an economist or healthcare expert, but when you get to your deductible, so you pay for your deductible. You pay for whatever you want, $2,000, $5,000, $10,000, $25,000. Up until that point, it's dollar for dollar. And then once you show XYZ insurance company that you've paid out, you show them your receipts or whatever mechanism is instituted, then the insurance kicks in, just like car insurance or something else. So that's if the patients are reaching in their pocket, that by itself, that'll solve the transparency issue. And the last point I want to make, and I'm beating it to death, and if Brennen, if you guys are tired of hearing about McCarran-Ferguson, I think it's really important. I mean, this is basically the antitrust exemption for the healthcare insurance companies.
Needs to be repealed too, yeah.
I investigated, who's doing what. So it was on our first town hall. So it passed the House easily last year. It was introduced by Paul Gosar, who's a dentist. He's a Republican from the rural part of Northwest Arizona. And he reintroduced it this year, but because of the partisan politics, he had DeFazio, who's a Democrat from Oregon, introduce it. So that way it was introduced by a Democrat. But it passed the House easily last year by like 400 and something to 7 or 8.
Wow.
And then Steve Daines from Montana introduced it in December, and it got held up in the judicial committee. And so the second day that we were there, and we were all mingling around the next day on Tuesday last week. But I went to Paul Gosar's office and actually spoke with the guy. I caught him in between some meetings, and he talked to me for 5 or 10 minutes. It was great. He is so about this McCarran-Ferguson. He said between that and HSAs for almost everybody, even Medicaid patients, where people have skin in the game.
Right.
And Ben Carson talked about, alluded to that in his talk too, that this thing could easily figure itself out. So I talked to him. He's all about that. He got this Democrat from Oregon to reintroduce it. The House is on board. It's really the Senate we need to work on, and the Senate Democrats. And we need to get in their face. And again, let's use our patience, because that is the key. The physicians are bound from talking about the prices and transparency. And this conversation may even be illegal due to the Sherman Act, right? Where physicians can't talk to each other about price. And correct me if I'm wrong. So we're not allowed to talk to each other about price because of the Sherman Act, but they get antitrust exemption to the McCarran-Ferguson.
That's right. Now, McCarran-Ferguson is a big deal. And I would encourage you all, if it does get through the House, I would encourage you all as physicians to reach out to Dr. Cassidy and all the other physicians in the Senate. I don't think there are many. I can't recall who the others are right now, but have them hear from you.
Well, that's one thing, if I may interject, that's one thing, Dr. Sussman, that you pointed out, that we have the patients in front of us and we should hand them a sheet. What we ought to do is, and I do have a couple of emails that are templated emails that I send my patients from time to time saying, hey, contact your congressman, send them this, just copy and paste this little blurb right here and send it on. Go ahead and send it on. And there, by the way, there's their phone number too, if you want to contact them as well. So that's always a great idea.
So let me tell you something. I'm from Philadelphia, so I'm a little bit cynical, so I apologize. I mean, you guys have to deal with the pollen in Texas. I have to deal with our lousy attitudes growing up in Philadelphia. But in any event, that's what you get for growing up with Philadelphia Eagles. It's, you were 3 years old. But
I think it's pronounced Eagles.
What was I going to say here? What did you say, David?
I think it's pronounced Eagles from where you
Eagles, that's right.
Eagles.
I thought you said something where you're going to, we're going to have to get into that arm wrestling. We're all going to be arm wrestling, but what was it? I lost my train of thought here. What was it?
You were saying you were from Philadelphia.
No, I was talking about. I looked at the people who had signed up to attend today's meeting, and it looked like there were about maybe 20 to 25. And when I'm looking at the participants here, there's 4 of us and there's 7 attendees. So to get to your point about the patients and telling them to email their congressman, what percentage of those patients actually follow through with that? So what I'm saying to you is, if we all had the same sheet, right? Because we're all bringing this together now. Like, the 4 of us are talking. This is our 3rd meeting, which is great. We just had this Free to Care where we brought some of the leading advocacy groups, physician and non-physician, together. If we all had the same message, the same sheet, and we were all handing it out to our patients the same day, and we had the ability to have them, even if they just signed off on it and wrote a little message, we could fax it for them right into the congressman's office, and all of a sudden they'd have this massive efflux. I mean, they would pull their hair out. So
that sounds like a perfect job for the Texas Public Policy Foundation representative that we have with us here. Maybe you could come up with something that's erudite enough to take on the McCarran-Ferguson Act. David, McCarran-Ferguson Act. Well, I hate to put work on you on a weekend.
I'll save David from this. When I was talking to Paul Gosar last week, his staffer said that he may be willing to come on to one of our town halls and speak more about this and his efforts, because I didn't even know he was going to be in the office. I was happy just to see the staffer. and he just happened to pass through, and we chatted. It helps that I'm a doctor in his district, but his staffer said, yeah, he may be able to come on, and he's really passionate about this and the HSAs and everything else. So I'll talk to Brennen, but I don't know if that's something that the audience here would like to have one morning, to have him come on and speak for 15 minutes, if I can try and wing that.
Sure, yeah, I'd love to hear more about HSAs and get a couple people talking about that. And also about, I think the next town hall we're going to have, that is going to be, we're trying to get doctors from the United States, from Singapore, from the United Kingdom, from Canada, and from Mexico. We're going to just hash it out and say what's the high points and low points of every healthcare. That's going to be interesting there.
That's going to be some arm wrestling right there. Yeah.
That's going to be fun. So that's a month from now. So just put that on your calendar. But yeah, so after that, I think that would be a good one to have on HSAs and alternate, not necessarily alternate funding mechanisms, but yeah, I guess that would be alternate ways to pay.
And Ben, to your point, Ben Carson mentioned that also in his talk about felt very strongly about HSAs.
Yeah, when he was running for president, he had it wasn't HSAs, it was health empowerment accounts. I think, is that what he was calling them? I mean, he had some good talking points on the powers of HSAs. So I'd really possibly get him on. I know he's a busy guy. That would add a little credibility to what we're doing. Hey, David, you're muted.
Oh, thank you very much. I forgot that I'm muted. I had my dog come in here. But no, HSAs are going to be a challenge because government, and this is my perspective, but government doesn't trust us to do what's right with our own money. They want to make those decisions for us. So there is some hesitation on the part of many in DC to give us the control over our own.
Funny.
Amazing concept. Yeah, Lee Gross is working on this out of Florida. Dr. Lee Gross has spearheaded an effort. We did a podcast last summer about HSAs and his efforts, and they're making some progress down in Florida and the local legislature there with they're calling, in fact, they're calling now direct patient care. I forget what they labeled it as, but they've come up with a different official term legislatively for the idea of no third party involvement between a doctor and physician. How amazing is that? By the way, I would consider that to be just business as usual without third party involvement, but they're having to come up with all these new terms for it, et cetera. And it's really sad. It's just sad that healthcare is so warped. And the people who are going to fix it are patients. They're going to be the ones to fix it.
That's right. We're 330 million strong.
Yep.
All right, everyone. Does anybody have any closing thoughts? Anything you want to bring up? And also in the show notes, we'll put all these links and everything. Kind of go back to your book, Kevin, if you want to send us your book, put all that stuff in there. Really like to promote everybody that takes their time out of Saturday mornings to talk about this. So if nobody else has any closing thoughts, we'll go ahead and end the recording and then just take it off from there. Let's see.
Appreciate it.
Anybody in the chat have any questions you want answered directly? I don't know if you guys have been reading that, but there's a lot going on.
It's been tough to keep up.
Yeah, no, like a drinking from a fire hose. All right. Well, all that will be posted with some follow-up and a blog post. So I thank everybody that participated this morning. Have a good Saturday.
Thank y'all. You too.
Thank you.
Thank you, guys. Good seeing you all.
All right.
You too.